Hello everyone, my name is Tanisha Lila Viwat. I am a PGY2 Internal Medicine at Texas Tech University Health Science Center. Today I'm going to present a case of paraspinal myositis in a patient with COVID-19 infection. As we know that patients with COVID-19 experience varying degrees of severity from asymptomatic to severe respiratory failure and multi-organ dysfunction. Myalgia is one of the most common presenting symptoms of COVID-19. However, myositis has been recently reported as one of the musculoskeletal involvements related to COVID-19 infection. Here we present a COVID-19 patient who developed paraspinal myositis, which has been rarely reported. Our patient is a 66-year-old female with a history of stage 3 diffuse large B-cell lymphoma with remission, status post-chemotherapy, and chronic deep vein thrombosis, who presented with a one-day history of hematemesis and hematochezia. She was admitted to the hospital due to hemorrhagic shock secondary to gastrointestinal bleeding. The patient developed a productive cough and shortness of breath on the second day of hospital admission, with hypoxemia and oxygen saturation of 88% on room air. COVID-19 testing was positive. Influenza A and B and parainfluenza were negative. COVID-19 related inflammatory markers were elevated, including CRP of 7.9, ESR of 51, D-dimer of 1531, and ferritin of 742. The patient was started on dexamethasone for COVID pneumonia treatment. The patient reported severe lower back pain without paresis or paresthesia on the 5th day of admission. MRI was performed on the 7th day of admission and showed evidence of myositis of paraspinal and posterior musculature. Serum creatinine kinase was sent and was elevated at 520 without evidence of myoglobinuria. Other serologic workup were negative for viral hepatitis, EBV, and HIV. On the 10th day of hospital admission, respiratory symptoms and back pain significantly improved. The patients no longer require supplemental oxygen. Inflammatory markers including the ESR and CRP were trending down, and creatinine kinase also came down to 91. For our discussion, musculoskeletal involvement related to COVID-19 infection can manifest a wide range of symptoms from asymptomatic to myalgia, myositis, dermatomyositis, myasthenia, asymptomatic rise in creatinine kinase, and even rhabdomyolysis with or without an increase in muscle enzymes. Although viral myositis can be caused by several viruses, including both influenza A and B, parainfluenza, enteroviruses, HIV, and hepatitis B and C. COVID-19-induced myositis has only recently been reported. The exact mechanism of injury is still uncertain, but several physiologic mechanisms have been proposed. The virus causes muscle inflammation by direct binding to the angiotensin-converting enzyme 2 receptor, which mediated direct entry and afflicts muscle fiber, leading to innate and adaptive immune activation, and a release of a large number of cytokines. In the field described cases of COVID-associated paraspinal myositis, MRI of the spine typically show bilateral intramuscular edema and enhancement with a T2 hyperintensity, which our patient's MRI showed the same feature. Nearby subcutaneous edema was also reported, but the edema in the paraspinal muscle was out of proportion to the superficial subcutaneous edema. Although there is no guideline available specifically for the treatment of myositis associated with COVID-19 infection, glucocorticoid therapy has been used and shown in various studies to decrease hospital mortality in patients with COVID-19 related cytokine storms. However, immunosuppressive treatment in myositis remained a debated topic. In conclusion, Physicians should be on the lookout for signs and symptoms of multi-systemic involvement and be aware of these clinical features and imaging findings when treating COVID patients. These are our references. And thank you for your attention. We appreciate your comment and also please stay safe.